Hello and welcome back. So we will continue our lecture on abnormal labor. This is the second part. In the last part, we were discussing actually obstetric fistula, and I recommended you watching some videos. The links are given here. So unfortunately, hundreds and thousands of women, young girls, they are married at a very young age before their 18th birthday. And how does it affect their lives? So they are at increased risk of having obstetric fistulas because their pelvises are not ready to give birth normally. And it's a major problem in the developing world in many parts of Asia and in Africa. See, in the developing world, one third of girls are married before the age of 18, and 1 in 9 are married before the age of 15. So that means in the next coming years, it suggests that 140 million girls will become wives before their 18th birthday. So the problem is when girls are married at an early age, then of course there are social pressures, right? So they because of social pressures or because of then their unawareness about different methods of contraception, they get pregnant early and they are at very high risk of complications like obstructed labor. They are at risk of having obstetric fistulas, and which can lead to poor perinatal and maternal mortality and morbidity. So, what are the signs of obstructed labor? There are many signs. Of course, that's why maintaining a partogram is important because partogram gives us at an early stage, like just it tells us just at a glance whether the progress of labor is going normal or it is slow. Okay, but even in many hospitals, partograms are not used. So, but there may be some late signs of obstructed labor. Okay. And one of the very famous ones, a characteristic one that's called the presence of a Bendel ring or the Bendel ring appear, Bendel sign. Okay. So, what does that mean is when we even inspect or palpate, okay, so on inspection or even on palpation, we see that the upper segment and the lowest part of the uterus, they are separated by this kind of ring. Okay, so normally we do not see it, right? And but Bandel ring is this appearance, this characteristic appearance. It's a late sign, unfortunately, of obstructed labor. And it basically means that the baby is unable to descend through the birth canal. Now, many of you may remember this image. It's the same which we used in scar rupture or VBAC lecture. What I want to tell you is that if a patient has epidural, and if even because in even in hospitals, right, under care of doctors and midwives, obstructed labor can happen because of different reasons, which are going to discuss in the next slide. So one of the signs is hematuria. Okay, and it does not mean that it is gross hematuria. So as always, please look into the tubing as well. Okay, so if we suspect poor progress of labor, or even if we suspect, for example, scar rupture, please always look at the tubing. Okay, do not wait to, for it to become gross hematuria or to come into the urine bag. Okay, so if there is even these like streaks of blood there, it means hematuria. That means that's a sign of obstructed labor. Okay, so why obstructed labor may happen? It may happen because of maternal reasons or it may happen because of fetal reasons. So for the maternal reasons, it may be there may be some problem in the bony pelvis. For example, it's a short woman, or maybe a woman has had fractures in the pelvis secondary to road traffic accidents, or even maybe there were some earthquakes. The woman was trapped under rubble, and then there were pelvic fractures. Or in poor societies, there may be as a child they might have had rickets, right? So if there is any problem in the maternal pelvis, that can lead to obstructed labor. Or there may be some soft tissue, for example a large fibroid in the lower segment or big ovarian cyst that can affect descent of the fetal presenting part. Or sometimes there can be problem in the shape of the uterus, like it can be, for example, a septate uterus. Or sometimes there can be obstruction because of some fetal malpresentation or malposition, so like this. right? Okay, so that may be a reason. Now, yes, secondary to baby, so it can be generalized or localized. Generalized, for example, the baby is huge, it's a macrosomic baby, or a localized means the baby, rest of the baby size is normal, but it's just one part which is enlarged. For example, it can be a sacrococcygeal teratoma, a big one, or it can be a gross hydrocephalus, okay? And sometimes it may be related to male presentation of the baby. For example, so a male presentation or male position, okay? So male presentation means either the baby's or abnormal lie of the baby. For example, if it's a transverse lie, no way this baby is going to be delivered normally, right? Even if it is fully dilated, it will never happen. Instead, there can be hand prolapse, because in transverse lie, shoulder is the presentation. Now, again, in brow presentation, we know that in brow is because the presenting diameter is almost 13 centimeter, which is way bigger than 10 centimeter. So brow presentation at any stage of labor, it needs to be delivered, even if it's a full dilatation. Now, in the first part of the lecture, I said there are three P's which we are going to discuss in this lecture. So first, we will grossly mention what are the causes of abnormal labor. So it can be because of poor progress, like the cervix is not dilating, or see, how did the WHO defined normal labor? It should be a single baby. This labor should have started normally without induction of labor, and it should go smoothly, right? So if there is, to begin with, if it's a multiple pregnancy, that's an abnormal labor. If it was induced because of any reason, diabetes, hypertension, IUG, or any reason, it's an abnormal labor. If there are problems in the fetal heart rate, which can be detected either by CTG or by passage of meconium, which is an indication it's an abnormal labor. And then we are going to, in the rest of the lecture, we're mainly going to discuss these three P's: poor progress. What causes them? What causes poor progress? Its first P is the so there are the three P's stand for. The first one is power. Power means uterine contraction, power of the uterus, because when uterus contracts, that leads to dilatation of the cervix. So if the power is insufficient, cervix is not going to dilate. Okay. And the second one is passenger. Who is the passenger in this whole story? Passenger is the baby, okay? So passenger is the baby. Now problem can happen to the baby, right? It can be a big baby, or it can have, say for example, a hydrocephalus or something, or it can be a male position, or it can be a male presentation. So second P is the passenger. Now, what is the third P? The third P is passage. What is the passage? It's the birth canal. And the problem can be in the birth canal. Like we said, some women can have a narrow pelvis. Even if it's not narrow, but if it's like, okay, it can be narrow, but because of it can be by birth or it can be acquired. Acquired, for example, secondary to trauma, birth, maybe say they may have an android pelvis, which is not the ideal pelvis, or platypaloid pelvis, which is again not ideal, because the ideal one is gynecoid. Now, so if so how do we define poor progress? It is, if we are performing vaginal examination every 4 hours, then it should be at least dilatation of at least 2 centimeter. If it is less than that, it's poor progress. Okay. Then delay in descent and rotation of the presenting part. Okay, so the baby, it's either it's, see, when we discussed mechanism of labor, there is a problem either in the rotation, like it can be in occipito-posterior, right? It did not turn into occipito-anterior, so that's problem in position. Fetal male presentation, there can be a problem in the presentation. For example, baby can be breech or brow or shoulder. Okay, and yeah, fetal position we already discussed. So now we are going to discuss these three P's: passenger, pelvis, power. Okay, so first we will start with abnormalities of the birth canal, which is the passage. Okay, the bony pelvis may cause delay in the progress of labor. That may happen because of abnormalities of the uterus or cervix. Okay, so there may be problem in the bone or problems in the cervix or even the uterus. For example, uterus is septate, cervix, previously there was loop excision of transformation zone, and there is scarring of the cervix, then it's not going to dilate because scar tissue loses elasticity. Okay. Unsuspected fibroids in the lower uterine segment can prevent the descent of the fetal head. Cervical dystocia is the same name which is used for like a non-compliant cervix. Okay, it does not dilate because of severe scarring or rigidity, usually as a result of previous cervical surgery, such as a cone biopsy. These days, cone biopsy is not performed. Instead, LEEP or LEDs is performed. So again, but if some women need repeated LEDs or loops, so they are more at risk. Now, CPD is a term which you need to understand. CPD stands for cephalopelvic disproportion. Cephalo is the term used for head, pelvis, pelvic is pelvis, right? So it's the disproportion between the head of the baby and pelvis of the mother. Okay, so it is related to passages and the passenger. Okay, so this CPD, cephalopelvic disproportion, can be absolute or it can be relative. Absolute means it is narrow, okay, like an android pelvis. So this pelvis will be narrow for all pregnancies. Okay, what if a woman has 6 pregnancies and she has an android pelvis? We cannot change it, right? So it's absolute CPD. Sometimes it's relative. Relative means even if she has a gynecoid pelvis, a baby may have a male position. For example, if it's occipito-posterior, right? So maybe in this pregnancy, it's relative CPD, but next pregnancy, if it's a normally presentation or normal position, that will be okay. That may be okay. Or even if this pregnancy, it's a macrosomic baby, next baby may not be macrosomic, right? So it's relative, okay? Relative to the baby. So CPD implies anatomical disproportion between the fetal head and maternal pelvis, large head, small pelvis, or a combination of the two relative to each other, maternal pelvic fractures or metabolic bone disease, like if there was rickets, okay? And fetal anomaly contribute to CPD, obstructive hydrocephalus, macrocephaly, and fetal thyroid and neck tumors, huge tumors. Sometimes it can be gross fetal thyroid goiters, okay? And relative CPD is more common and occurs with malposition or even malpresentation of the fetal head. Okay. So previously in 19 up till I think 1970s, they used to do X-rays to even when the woman was pregnant. They used to perform pelvic X-rays, and they used to use these certain diameters like obstetric conjugate and true conjugate. Like they used to measure from top of the pubic symphysis and the sacrum what is the distance, and they used to say, oh, this woman has CPD, and just perform an upland or elective C-section. Now it's obsolete. We do not do it. Then how do we know that a woman has cephalopelvic disproportion? It is just, see, if we suspect CPD, just let the woman go into labor until and unless it's absolutely like evident. For example, if there is a pelvic fracture, right, and there is gross, we know that there is gross distortion of the pelvis, then do not even try labor. But if there is, like, we think that this baby may be macrosomic, because ultrasound is not 100% accurate, there is always plus minus 10 to 15% of error. So if we think that, oh no, there may be, so let the woman go into labor, see if it progresses well, monitor very closely. If there is any evidence of poor progress, then perform C-section. So nowadays, evidence-based medicine, like if you're doing the best clinical practice, so labor is the best test to detect CPD until and unless it is already proven that it's grossly distorted pelvis or it's absolutely clear that there is disproportion between there is CPD. Okay, so rest of the lecture I'll continue in the third part.